Hello everyone and welcome to our module on heart sounds. Shown on this slide is Wigger's diagram, which I talk about in detail in another video, but it depicts all the events that occur during the cardiac cycle. And I just want to point out to you that the two normal heart sounds, S1 and S2, are part of Wigger's diagram. And so in this video, we're going to talk about the two normal heart sounds. We're also going to talk about a number of other heart sounds that are abnormal. So we'll start by talking about S1 and S2, which, as I just mentioned, are the two normal heart sounds heard as part of the normal cardiac cycle in all hearts. And each of these heart sounds, S1 and S2, has two components to it. One of the components comes from the left-sided valves, either the aortic or the mitral. When they close, they create one component of each of these sounds. And the other component comes from the right-sided valves closing, either the tricuspid or the pulmonic. Now, S1, the first heart sound, is usually single, and what we mean by that is that the two component sounds are very close together, and you can't distinguish the separate sounds with your ear. In contrast, S2 is often a split heart sound, meaning the two components of the S2 are far enough apart in time that you can audibly tell that there are two components to the second heart sound. So if you look at what I've drawn in this slide here, this is an EKG right here, and this is the QRS complex. And remember, the QRS complex represents the depolarization of ventricular myocytes. So when you see that, you know that the ventricular myocytes are contracting and the ventricle is pushing blood out of the chamber. So that is the beginning of systole. It starts right after the QRS complex. And at the beginning of systole, the mitral and tricuspid valves close. And those two components, which, as I said, are usually smushed together so they sound single, those two components create S1, and that's right at the beginning of systole. Then later, the chambers start to fill with blood and the aortic and pulmonary valves close, and those two sounds together make the second heart sound S2. And as I said, the two components of S2 are often far enough in time that you can audibly detect the two components. And so when you hear the S2 sound, now the heart is entering diastole because you're getting closure of the aortic and pulmonary valves, and the ventricles are going to start filling with blood again. And so now I'll play you an example of the two normal heart sounds. Try and appreciate that S1 and S2 are fairly close together, followed by a longer pause before the next S1 and S2. And that's because at normal heart rates, systole is usually shorter than diastole, so the longer pause between sounds represents diastole. So as I told you earlier in this video, S2 is often a split heart sound, meaning you can hear the two components of S2 separately when you listen with the stethoscope. And the way that splitting of S2 changes during the respiratory cycle can tell you something about what's going on in the patient's heart. So let's talk about that now. First, I'm going to talk about physiologic S2 splitting. This is the way S2 splits in patients with normal healthy hearts and no underlying pathology. In those patients, when they're exhaling, the difference between the two components of S2 is very minimal, and often S2 sounds like a single heart sound. However, when the patient inspires and takes in a breath of air, there's a slight increase in the delay between the two components of S2, and you can usually hear this split. And so this is called physiologic S2 splitting. S2 sounds single during exhalation, and S2 becomes split with inspiration. And the reason this happens is because there's a slight increase in venous return when patients inspire, and this delays the closure of the pulmonic valve by about 40 to 60 milliseconds, and this usually makes it sound split when you listen with your ear. So I'm going to play you an example of this now. The first couple beats, you're going to hear a single S2, and then you're going to hear it split into two components when the patient takes in a breath of air or inspires. So hopefully you're able to appreciate how the S2 sounded single initially, and then it split in the second half of the heart sound when the patient took in a breath of air. That's physiologic S2 splitting, something that can be heard in patients with normal hearts. So now let's talk about some abnormal forms of S2 splitting, and we'll start by discussing persistent splitting of the second heart sound. So in patients who have persistent splitting of the second heart sound, they have a small split in S2 even when they are exhaling. And then that split becomes even larger when they inspire and the pulmonic valve closure is delayed. So what's happening in these patients is they have delayed closure of the pulmonic valve, not just during inspiration, but even during exhalation. And that's what gives this persistent splitting of S2, a small split with exhalation, a larger split with inspiration. And the two conditions that cause this are right bundle branch block or pulmonary hypertension. In both of these conditions, there's delayed outflow of blood from the right ventricle and therefore delayed closure of the pulmonic valve. And the way I've always remembered this is persistent has an R in it, and that R stands for right-sided delay. There's some problem on the right side of the heart delaying closure of the pulmonic valve, either a right bundle branch block, like what's shown here, or pulmonary hypertension. Another abnormal form of S2 splitting is called fixed splitting. This occurs in patients who have an atrial septal defect, and it's high yield to know about this. So when patients have an atrial septal defect, which is a condition I talk about in videos in the embryology section, they have blood flowing across the ASD from the left side of the heart to the right side. This increases the right-sided flow, and this delays closure of the pulmonic valve. And so what patients get is fixed splitting, where there's the same degree of splitting present during exhalation and during inspiration. This is different from persistent splitting, where there's a small degree of splitting with exhalation and a greater degree with inspiration. In the case of an atrial septal defect with fixed splitting, there is the same degree of splitting of the second heart sound throughout the respiratory cycle. Now, differentiating this from persistent splitting with your stethoscope is incredibly hard to do, but I don't think they're going to ask you to do that on your boards. You just need to know the different conditions that cause persistent versus fixed splitting. And so in patients who have an atrial septal defect, they classically have a fixed split S2. They also classically have a systolic ejection murmur at the left sternal border from high flow across the pulmonic valve. And once again, I talk about this in detail in videos in the embryology section. And so now I'll play you a quick example of fixed splitting of the second heart sound. And then a final abnormal form of S2 splitting is called paradoxical splitting. This occurs anytime there's delayed closure of the aortic valve. So remember that in terms of the second heart sound, normally you get closure of the aortic valve first, followed by closure of the pulmonic valve. But if people have some underlying cause that delays closure of the aortic valve, then they get a situation where the pulmonic valve closes first, followed by a pause or a split, and then the second component of S2 comes from the aortic valve closing. And then when the patient inspires, closure of the pulmonic valve is delayed and the two heart sounds come together. So what you get in paradoxical splitting is a situation where the S2 is split during exhalation, but single during inspiration. This is basically backwards or the reverse of what you see in normal physiologic splitting of the second heart sound. So in this slide is a list of things that cause paradoxical splitting. All of these conditions delay closure of the aortic valve. So the aortic valve could close late if there's an electrical problem that delays the activation of the left ventricle and systole of the left ventricle. So patients who have a left bundle branch block or who have a pacemaker in their right ventricle, in both of these conditions, there's delayed squeezing of the left ventricle and therefore delayed closure of the aortic valve, and that leads to paradoxical splitting. There are also a number of mechanical causes of paradoxical splitting. All these conditions delay or slow outflow of blood from the left ventricle, and therefore the aortic valve closes late. So you can see paradoxical splitting for this reason in patients with severe LV systolic failure, in patients who have aortic stenosis, and also in patients who have hypertrophic cardiomyopathy. And the way I've always remembered this is that paradoxical splitting means there's some left-sided delay. And so here's a summary of the various different forms of S2 splitting. So in physiologic splitting, S2 is single with exhalation and becomes split when the patient inspires, and this is normal respiratory variation of the second heart sound. In persistent splitting, remember the R is for some right-sided heart problem. That could be a right bundle branch block or pulmonary hypertension. A fixed split is caused by an atrial septal defect, and paradoxical splitting, the L at the end, is for left-sided heart problems like left bundle branch block, cardiomyopathy, or any of the things we talked about a few slides ago. And so nowadays, listening to the heart and identifying changes in the heart sounds is something that's not done very commonly, and that's because we have such wide availability of echocardiography. But decades ago, before echocardiography, listening with the stethoscope was much more important for diagnosis. And sometimes when it was hard to tell what the heart sounds were doing, people would actually record the heart sounds and create what's known as a cardiac phonograph. So this is an example of a phonograph. This is a patient on top with a normal S1 and S2. You can see the two heart sounds repeating over and over. At the bottom is a patient with a fixed split S2. You can see that the second heart sound is always split. So nobody really does this anymore, but it is possible you could see this on your board exams. And all you need to know is that the two big lines here represent the first and second heart sound, and they're either single, like for S1 here, or they could be split, like this S2 example here. You'll sometimes hear board questions say that the patient has a loud P2, and what they mean by this is the patient has a loud pulmonic component of the second heart sound. Anytime they tell you this, they're trying to tell you the patient has pulmonary hypertension. That always causes a loud P2 because when pressure is high in the pulmonary arteries, there's very forceful closure of the pulmonary valve, and this makes a loud P2. Normally, P2 is not heard at the apex of the heart, so if you can hear it at the apex, it's loud. This is one way in clinical practice you can sometimes identify a loud P2. They're probably not going to ask you to know this for your boards, but they are going to expect you to know that a loud P2 indicates some cause of pulmonary hypertension. Okay, now let's move on from S1 and S2 and talk about S3 and S4. These are not normal heart sounds. These are pathologic, abnormal heart sounds heard in patients with underlying heart disease. They both occur in diastole during filling of the left ventricle. So if you look at the bottom of the screen here, between S1 and S2, this is systole. After S2 until the next S1, this is diastole. S3 is heard early in diastole and S4 is heard late in diastole. We'll talk about both of these in detail in just a minute. They are both low-pitched sounds, usually heard best with the bell. If you look at this drawing, this is the bell of the stethoscope right here, and that's the part of the stethoscope you use usually to best hear S3 and S4. And once again, as I said, S3 occurs early in diastole. It's an early filling sound with filling of the ventricles, and S4 occurs late in diastole. So it's super ideal to know that usually the situation where you hear an S3 is in patients who have acute heart failure. These patients are volume overloaded and they have high pressure in the left atrium. Because the pressure is high in the left atrium, it drives blood very quickly into the left ventricle when the mitral valve opens. So you get very rapid early filling of the left ventricle, and as that blood slams against the wall of the left ventricle early in diastole, that's what creates the S3. This heart sound has been well described as being associated with high left atrial pressure and also high left ventricular end diastolic pressure, both findings seen in patients with volume overload and acute heart failure. The patients who get an S3 from acute heart failure are said to be pushers. They have high left atrial pressure pushing blood into the left ventricle. And for this reason, the presence of an S3 is a very specific sign of high left atrial pressure. And whenever they tell you there's an S3 in a board question, they're telling you the patient has high left atrial pressure. Now, you should also be aware that you can sometimes hear an S3 in patients with normal hearts, especially in younger patients and in women who are pregnant. These patients are said to be suckers. Their left ventricle is so healthy, it relaxes very quickly and it basically sucks blood into the left ventricle so fast that that blood slams against the wall of the left ventricle and creates the S3. So the two key situations to know of when an S3 can be normal is going to be in a young, healthy patient or in a woman who is pregnant. So like I told you before, S3 is a low-frequency sound best heard with the bell of the stethoscope. It's also best heard when the patient is in the left lateral decubitus position. That means you have the patient lie on their side, like what's shown here, and you reach over their back and listen to their chest. And when you put them in this position and you use the bell of the stethoscope, the location where you'll loudest hear the S3 is usually at the apex of the left ventricle. And now I'll play you an example of a patient with a normal S1 and S2, followed by an S3 in early diastole. Okay, now let's talk about the S4 heart sound, which, as I said, occurs in late diastole. The thing to know about an S4 is that this is an abnormal heart sound heard in patients who have a stiff left ventricle. So what are some examples of patients who have a stiff left ventricle? Well, patients who have long-standing hypertension will have left ventricular hypertrophy and their ventricle will become stiff. Patients with hypertrophic cardiomyopathy also have thickened left ventricle walls that can be stiff. And then patients who have diastolic heart failure also classically have poor relaxation of the left ventricle and a stiff left ventricle. And so all these groups of patients are places where you can hear an S4. The cause of the S4 is late filling of the left ventricle due to the atrial kick. So remember that blood moves from the left atrium down into the left ventricle across the mitral valve. The early part of blood moving in this way is passive. Basically, blood is just flowing from the left atrium to the left ventricle. But the late part of blood movement is caused by the left atrium contracting and squeezing blood into the left ventricle. And when that blood slams into a stiff wall of the left ventricle, that's what creates the S4 heart sound. And so because the S4 requires the left atrium to contract and kick, you cannot get an S4 in a patient with atrial fibrillation. It's high yield to know this. This is atrial fibrillation shown on the slide here. When this is ongoing, patients don't have normal contraction of their left atrium, so they are unable to have an S4. And now I'll play you an example of the two normal heart sounds followed by the S4 late in diastole. So hopefully you heard the abnormal heart sound, the S4. Basically, it comes before S1. You hear like ba-bump, bump, ba-bump, bump. And that first bump is the S4 followed by the S1. And that's because the S4 occurs late in diastole. There is something called a right-sided S3 and S4. These are abnormal heart sounds caused by abnormal function of the right ventricle, not the left ventricle. They occur through the same mechanisms as the left heart sounds we've been talking about. So right heart failure can give you a right-sided S3, right ventricular hypertrophy or right ventricular stiffness can give you a right-sided S4. These can be heard by examining the right side of the chest in patients. In clinical practice, these heart sounds are very hard to hear, and you'll probably never hear them, but you may see a board question that describes a right-sided S3 or S4, and you should know they're talking about problems involving the right ventricle. So the S3 and the S4 are abnormal sounds that occur in diastole. Now we're going to talk about clicks, which are abnormal sounds that occur during systole. So there are two types of clicks you can hear, one that occurs early in systole just after S1, and another that occurs in mid to late systole. The early clicks in systole are called ejection clicks. They occur early in systole, and the definition of early is before you can feel the carotid pulse with your fingers on the patient's neck. So if your fingers are on the patient's neck and you hear the click before you feel the pulse, that's an early systolic click or an ejection click. And the cause of an ejection click is usually a bicuspid aortic valve. The clicks that occur later in systole are called non-ejection clicks. They occur after you can feel the carotid pulse. And the classic cause of a non-ejection click is mitral valve prolapse. So that's a nice segue into mitral valve prolapse. So let's talk about this condition now. So in patients with mitral valve prolapse, they have billowing of their mitral valve leaflets above the annulus or the rim of the mitral valve. To understand this, let's look at my little cartoon on the screen here. So normally, when the left ventricle squeezes and contracts, it closes the mitral valve like this. The leaflets come together and seal so blood can't go backwards, and the leaflets do not billow up into the left atrium, and they don't extend above the annulus, which is the rim of the valve here. In patients who have mitral valve prolapse, however, the leaflets are stretchy, so they billow up into the left atrium like this, and they rise above the rim or the annulus of the valve, and this condition is called mitral valve prolapse. And when the leaflets billow up and snap like this, I think of it kind of like a parachute snapping open. It creates a clicking sound with each cardiac cycle when the left ventricle contracts. Now, as you can imagine, if the leaflets are stretchy like this, they often let a little bit of blood leak backwards into the left atrium. And so mitral valve prolapse is commonly associated with mitral regurgitation. The two conditions usually go together. Most patients who have mitral valve prolapse also have some degree of mitral regurgitation. And then, as I said, the billowing of those leaflets causes a systolic click. So mitral valve prolapse classically causes that non-ejection click we talked about on the last slide. And one thing to be aware of, don't confuse this with the opening snap of mitral stenosis. Because these are both mitral valve conditions, students often mix them up. But the opening snap of mitral stenosis is a diastolic heart sound. The click of mitral valve prolapse is a systolic sound. And I've always kept them together through this little mnemonic here, pro-click, steno-snap, to remind me that prolapse causes the systolic click and stenosis causes the diastolic opening snap. So shown on this slide is a visual depiction of what the heart sounds sound like in patients with mitral valve prolapse. So you have S1, the first heart sound, which kicks off systole here. And then you get the click, which is usually in mid to late systole, and it's usually followed by the murmur of mitral regurgitation. Like I told you, the click and the murmur usually go together. And then you get the second heart sound representing the end of systole. So I'm going to play you an example of what mitral valve prolapse sounds like now. I will let you know up front that this is a very difficult condition to identify by the oscillatory findings. In board questions, they are almost certainly going to give you lots of clues in the question stem, so that you don't need to rely completely on the audio to make a diagnosis of mitral valve prolapse. But nevertheless, I'll play you an example of what it sounds like now. The first few beats are just going to be S1 and S2 with the murmur of mitral regurgitation, and then after a few beats, you'll hear the click added in. And that concludes our module on heart sounds.